Hello, good morning everyone. Good morning everyone, dear friends. This is Dr. Jambukeswaran, PrepLadder's orthopedic faculty for you. Today we are going to see LRR for our FMGE exam. Okay, so this is lot result. Am I audible and visible clearly? Please. Yes. Okay, that's fine, dear friends. Good. So this is, okay, everything is visible and audible. Excellent. Okay, yes. So, yes, very good, dear friends. So this is a last resort revision. So quickly, some important topics for FMGE. In a period of 1 hour 45 minutes, we are going to see some important topics. Straight away going to question number 1. Sample question number 1. Identify the image. Identify the type of shoulder dislocation. Look at this image. Is it anterior, posterior, inferior or recurrent? Okay, give me the answer. Yes. Okay. Yes. AG Pulse has given the right answer. Given the right answer, yes. Okay. Yes. Okay. So, okay, many of you are giving the answer. See, few of you have answered it correctly. Many are telling a different answer. I will give you the answer. This position, you see this patient, he is lying like this. Okay, so this is called salute position. This is called salute position. This is called salute position, and classically this happens in inferior shoulder dislocation. Inferior shoulder dislocation. Okay, so this is inferior shoulder dislocation, right? They have asked. Now, by looking at the attitude of the upper limb, easily we can diagnose whether this is anterior, posterior or inferior. I will tell you, in anterior shoulder dislocation, we all know that is the commonest type of shoulder dislocation. The arm is extended, abducted, externally rotated. So a patient will come to you like this. This is the attitude of the commonest dislocation, anterior. Posterior shoulder dislocation, patient's arm is adducted, internally rotated. They will hold the affected limb with the unaffected one like this. This is the position of posterior shoulder dislocation. This is called sling position. And the rarest shoulder dislocation is inferior. The patient will be hyperabducted and patient will come to you like this, and this is called salute position. That is why the humeral shaft is erected. That is why inferior shoulder dislocation is otherwise called luxatio erecta, which is the rarest. Commonest type of shoulder dislocation anterior, rarest type is inferior. In image based, several times they had asked anterior. Inferior is also there in the book. So this can be a new question. So with this, we will see. Yes, very good. Dr. Meswe has answered salute sign, sling position. Okay, very good, dear friends. Excellent. Quickly, we will see. Commonest joint in the body to get dislocated is shoulder. Okay, commonest. And in the commonest, one should be very careful, dear friends. Please focus your full attention on me. If they ask a question, most common joint to undergo dislocation, the answer is shoulder. If they specifically ask most common joint to undergo dislocation in children, if they use the word children, answer is not shoulder, dear friends, answer is elbow. Commonest joint to get dislocated in a child, elbow. Commonest joint to get dislocated in an adult is shoulder. Okay, and there are 3 types of dislocation: anterior, posterior, inferior. The commonest is anterior, most common type. Okay, this posterior is next common, rare. The rarest is inferior dislocation. This is otherwise called luxatio erecta. You see, it is only 0.5 percentage. This anterior shoulder dislocation is divided into 3. Anterior shoulder dislocation means head of the humerus is lying in front of the glenoid cavity, that is anterior. So if it is there when the head of the humerus is underneath the coracoid, so this is the coracoid process. So this is called subcoracoid, subtype of anterior, and this is the most common. It can be below the glenoid, which is called subglenoid. You see, this is the glenoid cavity. Head is lying beneath glenoid, it is subglenoid, very rarely subclavicular. The head of the humerus can be below the clavicle, subclavicular. Okay, so now let us revise. Shoulder dislocation is divided into anterior, posterior and inferior. The most common is anterior. Anterior shoulder dislocation is again subdivided into subcoracoid, subglenoid, subclavicular. Among the subclassification, the most common is subcoracoid. So, crystal clear point. If they ask a question, most common type of shoulder dislocation, our guys and girls should answer subcoracoid type of anterior shoulder dislocation. Subcoracoid type of anterior dislocation. Then everything is complete. The least common type without controversy, luxatio erecta. Okay? Yes. Now, I want you to again and again ask the question is Bankhart's lesion, Hill-Sachs lesion. These two questions repeatedly comes in FMGE, it comes in NEET PG, any entrance of our country, because practically these lesions are very important. Bankhart's lesion, sir, is it enough on 50% on IES scores 50%? Yes, yes, good. Okay, I do help you. Okay, right. Sammi Kumar, yeah, it is enough. Okay, it is enough. Okay, yes. See, our aim is to clear FMGE very safely. That's all. Okay, and that is easily possible. These are the important topics. Okay, yes, please concentrate. Bankhart's lesion is a lesion in the soft tissue. Bankhart's lesion is a lesion in the soft tissue. So, which soft tissue is involved? Glenoid labrum. Glenoid labrum, soft tissue. So, what is Bankhart's? A tear in the antero-inferior aspect of the glenoid. This word antero-inferior is very important. Okay. It is a lesion in the Bankhart's is a lesion in the antero-inferior aspect of the glenoid labrum. Okay. So, I used to teach my students the mnemonic BAI, boy. Okay. That's a mnemonic. Bankhart's antero-inferior. Bankhart's antero-inferior. This is how we used to remember. And see, this is the commonest lesion that is happening in shoulder dislocation. So 100 cases are coming, shoulder dislocations are coming to us. 85 cases will have this. That is why this is the most common lesion, and this is otherwise called an essential lesion. So you see this diagram, there is a tear in antero-inferior aspect of the glenoid labrum. Since it's a soft tissue lesion, this can be detected only in MRI. It can be detected only in MRI. Okay, you see, this is how in MRI it look a lesion in the antero-inferior aspect of the, yes, boy, Pujita, Subba Reddy, Anubhav Avasti, all of you are given the mnemonic also, excellent. Kastuba, okay, yes, Kastuba Sai, you have given the right answer, excellent. So, this is Bankhart's. Hill-Sachs lesion is a bony lesion. Hill-Sachs lesion is a bony lesion. What is that? There is an osteochondral depression or defect in the posterolateral aspect of head of the humerus. So, I used to teach the mnemonic for Hill-Sachs lesion. Hill-Sachs famous computer company HPL Limited, HPL, Hewlett Packard. So, HPL, Hill-Sachs posterolateral. Bankhart's antero-inferior. Boy is for Bankhart's, HPL is for, so that there won't be any confusion, because they are asking this question. Hill-Sachs is posterolateral, posteromedial, antero-inferior, something like that they are asking. So, it should be very clear. Hill-Sachs lesion is posterolateral defect in head of the humerus. It is seen only in 25% of the cases. Larger the defect, greater the chance of recurrence. New aptly gives this Hill-Sachs lesion as one more terminology. This is otherwise called hatchet deformity. You see in this bone, you are able to see a depression here, posterolateral aspect of head of the humerus. That is the Hill-Sachs lesion. Okay, right. What is the significance of this Bankhart's lesion and Hill-Sachs lesion? When Bankhart's lesion and Hill-Sachs lesions are present, they say this shoulder will go for recurrent dislocation, more prone for recurrent dislocation. So Hill-Sachs lesion is a bony lesion. So this can be easily seen in a good X-ray. X-ray is enough. Maximum CT scan. Best seen in CT scan. Bankhart's lesion is a soft tissue, so that is seen only in MRI. That's seen only in MRI. The third lesion is humeral avulsion of glenohumeral ligament. HAGL. Humeral avulsion of glenohumeral ligament. Okay, so this is when there is combination of Bankhart's plus Hill-Sachs plus Hagel, humeral avulsion of glenohumeral in the same patient at the same time. This is called unhappy triad. This is called unhappy triad. Unhappy triad, which carries very good. Everybody is answering superb. Nilesh Shah, excellent. Excellent Nilesh, excellent. So this is called unhappy triad. And when this combination is there, it's a terrible combination, a terrible triad. 100% that joint will go for recurrent dislocation. That is why this is not an MCQ, dear friend. All these are MCQs. The point which I am going to tell is not an MCQ. This is a life teaching for you, because many of you may be interested in taking ortho. What I am telling, one investigation which you cannot avoid in a shoulder dislocation is MRI. We know MRI is costly, around 6,000 rupees. But when somebody, especially a young individual, develops shoulder dislocation, kindly take MRI. Because when Bankhart's lesion is there, immediately you have to repair that. Otherwise, the joint will go for recurrent dislocation. Okay, so MRI, don't think it's a luxurious investigation. It is a very important, must-do investigation nowadays in case of shoulder dislocation. Because book says 85% of them will have Bankhart's lesion, which can be diagnosed only through MRI. Okay, so this is the take-home message. Now, coming to clinical features, all these questions have been repeated several times. Number one, attitude of the upper limb in case of anterior shoulder dislocation. Now we are going to see anterior shoulder dislocation. You see, arm is extended, abducted, externally rotated. Patient will come to the OP like this. Number two, when you see normally, this is a ball and socket type of joint. When ball is inside the socket, you can see the deltoid contour. You can see the deltoid contour. When ball is out of the glenoid socket, deltoid will become flat. So the deltoid contour is lost. You see here in this image, a beautiful image. So deltoid contour is seen. Here it appears flat. Okay, I will rub it. You just see. This is the easily you can say this is posterior shoulder dislocation. Number two, there is hollowing below the acromion. Here below the acromion, I am able to see a dimple, a hollow here. And this is called the sulcus sign. That is called sulcus sign. Then Hamilton ruler's test. Take a ruler, keep it over the acromion. Since the deltoid contour is lost, acromion flushes with the skin throughout till the lateral epicondyle like this. Okay, so this is called Hamilton ruler's test. Another important thing, take an inch tape, measure the girth or width of the axilla. Measure the girth or width of the axilla, right? So the girth or width of the axilla on the affected side is increased, and that is called Callaway's test. That is called, so the width of the axilla is increased, and that is called Callaway's test. Then comes Bryan's sign. This is very important, easily seen sign. Normally you can see an anterior, this is called anterior axillary fold. I will rub it, you see the anterior axillary fold. Bryan's sign on the affected side, anterior axillary fold is pushed down. Okay, so you see the anterior axillary fold here, it is here, it is here. So it is pushed down. On the affected side, anterior axillary fold is pushed down. That is called Bryan sign. Then a very important test, Dugas test. I said patient, it is arm is extended, abducted, externally rotated. So normally if I ask the patient to touch the opposite shoulder, if your shoulder joint is normal, easily you can touch the opposite shoulder. This is easy. If it's a case of anterior shoulder dislocation, arm is extended, abducted, externally rotated, patient cannot touch the opposite shoulder. Patient cannot touch the opposite shoulder. That is called Dugas test. That is called Dugas test. Certain books are using a different name for Dugas test. So it has one more name. Better know that name also. This is otherwise called Yoakum test. It's otherwise called Yoakum test. Okay. Yes. Right. Okay. So this is called Dugas test, otherwise called Yoakum's test. Okay. Yes. Okay. Okay. Excellent. Now coming to X-ray. You see, yes, Dr. C. Shan has said that you have some. Yes, Dr. C. Shan. You just after the session is over, you please come to the chat box. I will help you. Okay. Yes, I will help you. Yes. Very good. Then comes. Then you look at here over the deltoid. Over the deltoid here, loss of sensation will be there. This is because of compression of the axillary nerve. This is called regiment badge sign. Regiment badge. Like your army officer wearing a regiment badge. Okay. So here the sensation is lost over the deltoid because of compression of the regiment badge. Okay, so that's called regiment badge sign. All these are asked questions. Now coming to X-ray, best X-ray view. Normally in OP you will take AP view. AP view is different. True AP view is different. True AP view means, you see, suppose for example I want to take the right shoulder X-ray. I am lifting the left shoulder by 40 degree. This is the plate, X-ray plate. Right shoulder is close to the plate. Opposite shoulder is tilted to 40 degree. This is called true AP view. This is the best view to see the shoulder dislocation. True AP view is otherwise called Grischer's view, and this is the view of choice. When you take a proper true AP view, X-ray will appear like this. This is normal shoulder joint. You see head, and this is the glenoid. So it is normal. Okay, this is normal. This is anterior shoulder dislocation. You see glenoid cavity is superimposed with head of the humerus. Glenoid is not seen clearly because head of the humerus is obscuring the view of the glenoid cavity. This is anterior shoulder dislocation, and this is the classical view, and the view is called Grischer's view. Okay, now coming to treatment, the first employed technique was Hippocrates method. Very effective. Don't think it is ineffective. Very effective. But the problem, it is playing with morality or dignity of the patient. Nowadays you can't do. That is why it is outdated. Okay. Nowadays, why I will tell you. The patient has to come and lie down on the floor like this. The examiner will catch hold of the upper limb. The orthopedician will catch hold of the upper limb. Foot is taken. His foot is kept in the axilla of the patient. So I am pulling with my upper limb, I am pushing with my lower limb. Traction and counter traction. Slowly adducting. The joint will get reduced. Very effective method. But when you treat a private patient like this nowadays in 2026, you will be sued. That is why it is outdated. During Hippocrates era, nobody, because doctor was considered as a god. Nothing will go wrong against a doctor. Yes or no? Now it is not possible. Very effective method. But outdated because it's playing with morality of an individual. The next technique that was all end of the session, sir, can you please? Yes. Dr. Arun Prasad. Arun Prasad, I will tell you. Yes, I will tell you. Okay. Yes, Arun Prasad, I will do it. Right. You see, next method is called Stimson's gravity method. Next method is called Stimson's gravity. Put the patient in prone position in a couch. Ask them to hang his arm. Tie a weight here. With gravity, shoulder will get relocated. This is Stimson's gravity, not very effective. Then comes the classical method. This is the treatment of choice. This is the method of choice. This coach's method is called team technique. T stands for traction. E stands for external rotation. A stands for adduction. M stands for medial rotation. Medial rotation is otherwise called internal rotation. Medial rotation is otherwise called internal rotation. Okay, internal rotation. So what is that? Patient is there. Okay, somebody in the axilla they are giving. Yeah, so I used to demonstrate with my okay, so you see here, you just give traction. Okay, somebody is giving counter traction here. So it is traction. Okay, external rotation, adduction, internal rotation. Within 10 seconds, you can reduce this shoulder dislocation. This coach's method, otherwise called team technique, is the method of choice. Okay, so this is the treatment of choice. Marvelous. Okay, many of you have, Sai Rohit, any of you have answered this. This is the treatment of choice. Coming to complication of anterior shoulder dislocation, you see, most common nerve that is damaged is axillary nerve. The next common nerve that is rarely affected is musculocutaneous. And you dear friends, I want you to concentrate on this point, because one of the PG entrances in our country, the nerve that is damaged in shoulder dislocation, they had not given axillary in the choice. Axillary is the most common nerve that is involved. Rarely musculocutaneous nerve is also involved. This was an asked question. So both the points you should know. Most common vessel without controversy, maxillary artery, and shoulder dislocation can cause a rotator cuff tear. Rotator cuff tear means there is a tear in supraspinatus, infraspinatus, teres minor, subscapularis. Okay, so this is the rotator cuff muscle. Supraspinatus, very good. Sits. Supraspinatus, excellent man. Okay, Anubhav, Avasti, superb. Okay, so it is supraspinatus, infraspinatus, teres minor, subscapularis. Tear can happen. Recurrent dislocation is a troublesome complication. I told you recurrent dislocation is more common when the patient is having an unhappy triad. That is Bancott's plus Hill-Sachs plus Hegel deformity. Right? Again, more common in right. Now coming to posterior shoulder dislocation. Mechanism of injury in anterior shoulder dislocation is fall on outstretched hand with the upper limb in extension, abduction, external rotation. That's the most common. Posterior shoulder dislocation usually follows a convulsive seizure disorder or electric shock. This was an asked question. History they had given, some 20-year-old something, they had given known epileptic. What kind of shoulder dislocation? They had asked this question. Okay, so electric shock and convulsion predisposes posterior shoulder dislocation, right? The special point here, in anterior shoulder dislocation, the arm is extended, abducted, externally rotated like this. Arm was like this, yes or no? In inferior shoulder dislocation, the humerus is hyperextended. In posterior shoulder dislocation, the limb will appear near normal because it is adduction, internal rotation. It's called sling position. Patient will come to OP only like this, unless otherwise he will come to OP like this. What you can identify? Patient has to tell he is having pain. Okay, so the attitude, the upper limb appears near normal. Okay, because most of us when we stand, we are standing only like this. The patient will be in this position only. It's called sling position. Okay, and the thing is, in X-ray, in anterior shoulder dislocation, in inferior shoulder dislocation, no named radiological sign. Only in posterior shoulder dislocation, you have named radiological sign, and two signs are there. One is called empty glenoid sign. Empty glenoid sign is other is called vacant glenoid sign. This is sign number 1. Okay, what is that? When you take an X-ray, you see this is the glenoid cavity. This is head of the humerus. The gap will be there, and the gap is more than 6 millimeters. This is a criteria. Very, very important point. This is a criteria. Only when the gap is more than 6 millimeter, that is posterior shoulder dislocation, and the glenoid is seen clearly vacant or empty. That's why it's called empty glenoid sign. In anterior shoulder dislocation, you see here, you are not able to see the glenoid cavity because head is in front of the glenoid. So you are not able to see the glenoid. Here, head is behind the glenoid. So easily you can see the glenoid cavity which is empty. The glenoid cavity which is empty. Okay. Right. Next is the head of the humerus is adducted and internally rotated. The head is internally rotated, sling position. When the head is internally rotated, you cannot see the greater tuberosity, lesser tuberosity. So the head will appear like a bulb. Appear like a bulb. Okay, so this is called light bulb sign. Light bulb sign. Okay, rounded appearance, light bulb sign. In treatment of posterior shoulder dislocation, you should give traction. In anterior, what I said, Koch's method, traction, external rotation. You should never ever attempt external rotation. Should not be attempted in posterior shoulder dislocation. When you do external rotation in posterior shoulder dislocation, it will go for neck of humerus fracture. It will go for neck of humerus fracture. Should never fracture humeral head. Should never ever attempt external rotation. But external rotation is the main step in anterior. That is why before treatment, we should be very clear it is anterior or posterior. That's all in posterior shoulder dislocation. Inferior shoulder dislocation, rarest type you should know, luxatia erecta, and this is hyperabduction injury. Okay, salute position. That's all, nothing special. We will move on to the next question. Look at the X-ray and give the diagnosis. Is this a lateral condyle fracture, elbow dislocation? Is this the supracondylar fracture or radial head fracture? Yes. Yes, dear friends. Yogesh Dixit has given the right answer. Prajav, Dr. Miss. Yes, superb. Neha Singh, excellent man. All of you have given the right answer. Superb. And this is the classical X-ray of a supracondylar fracture. And this sign is called fishtail sign. This sign is called fishtail sign. Okay. Quickly, in 5 minutes, we will see revise last resort revision of supracondylar fracture. Supracondylar fracture is common in children below 10 years. Point number 1. More common in boys. Point number 2. More common on left side. Point number 3. Fall on outstretched hand with elbow in extension is the most common. Foosh on extended elbow is the most common mechanism. Point number 4. Marvelous. Okay. Coming to clinical feature, you make the baby sit down in a stool, in an examination stool. Watch the baby's arm from the side, from the lateral angle. You just see the arm will be S-shaped. S-shaped arm. You see here, like this. An S-shaped arm. The diagnosis is supracondylar fracture. Then you see in the lowermost portion of the arm, over the anterolateral aspect, over the lower anterior aspect here, when you see, you can see the skin is puckered. The skin is puckered. There is puckering of skin here. It will look like a dimple of your cheek, and that is called a dimple sign. Look at this. What is the mechanism? You see, any fracture has two fragments. Supracondylar fracture is happening in the metaphyseal area. The small chunk, the small is the distal fragment. The big shaft of the humerus is the proximal fragment. So the proximal fragment comes, pierces the brachialis muscle. The proximal fragment comes and pierces the brachialis muscle. That piercing of brachialis muscle will cause puckering of the skin around that bony fragment, and that is called dimple sign. So this is sign number 1, this is sign number 2. And the third important thing, the isosceles triangle or equilateral triangle which is formed in the elbow joint. What is that? In a fully flexed elbow, you mark tip of the olecranon, you mark the medial epicondyle, you mark the lateral epicondyle, you connect this, you will get what is called an isosceles triangle. You will get an isosceles triangle. The triangle is well maintained in supracondylar fracture. The 3 bony points, the triangle is well maintained in supracondylar fracture. You see, this is the medial epicondyle, this is the lateral epicondyle, this is the olecranon. It's maintained because fracture is happening above the condyles. That is why it's called supracondylar fracture. When the triangle is disturbed, this is in case of elbow dislocation. The case of elbow dislocation. So the triangle is disturbed in elbow dislocation. The triangle is maintained in supracondylar fracture. Okay? Yes. And coming to types of supracondylar fracture, 2 types are there. Extension type, which is the most common type. Asked question. Most common type of supracondylar fracture is extension type. Flexion type is only 2%. The extension type is again subdivided into posteromedial, posterolateral, and the most common type is posteromedial. So the most common type of supracondylar fracture is posteromedial type. Posteromedial extension type is the most common type of supracondylar fracture. But nerve injury is more common in the posterolateral type. Nerve injury is more common in the posterolateral type. And the nerve that is commonly involved is anterior interosseous nerve. The most common nerve that is injured in supracondylar. Yes. Okay. Right. Guys, I think I am visible now. Okay. I am visible now. Yes. Okay. I am visible now. Right. Fine. Okay. Good. You see here, the most common nerve that is injured in supracondylar fracture is anterior interosseous nerve. Okay. One time they asked a question, most common nerve that is injured in flexion type of supracondylar fracture. This is the rarest possibility. But in MCQ, no, we don't know which sadist is setting the paper. We don't know. This flexion type of supracondylar fracture, the nerve that is commonly damaged is marvelous, man. Yes. Sainsha Gupta, you have answered. Okay. Superb. Okay. So it is ulnar nerve. Marvelous, man. Ulnar. One minute, please bear with me. The screen. I think, okay. Now it is set. Now I think it's set. Good. Okay. Yes. Okay. So screen black and okay. I think it is right. Okay. Now good. Okay. So I repeat, dear friends, please focus your full attention. I repeat the same point. You see here, most common type of supracondylar fracture is extension. And the most common nerve that is damaged is anterior interosseous nerve. Rarest type of supracondylar fracture is flexion. If they specifically ask, and once they had asked this question, rarest type, okay, it is flexion. The nerve that is most commonly involved in flexion type of supracondylar fracture, then the answer is totally different. It is ulnar nerve. Totally it is different. It is ulnar nerve. It is ulnar nerve. Okay, yes. We will move on to the next thing. Don't forget this Gartland classification, because only when you know, I am not taking it unnecessarily, only when you know the type 1, type 2, type 3, you can write correctly the MCQ for the treatment, because they are specifically asking type 1 supracondylar fracture, what is the treatment? Type 2, what is the treatment? They are asking question. So very simple. Type 1 Gartland is just a crack fracture, there is no displacement. Just a crack fracture, there is no displacement. Type 2, anterior cortex is open, posterior cortex is intact. This is type 2. Type 3, totally displaced. This is type 3. Okay. Now coming to the X-ray, 4 signs you should know. Fat pad sign, teardrop sign, disturbed. Teardrop sign, disturbed. Fishtail sign and crescent sign. These 4 signs. Now you see, that is a normal elbow X-ray. This is the normal elbow X-ray. Okay. Here, when you closely watch, you can see here and here a gaseous shadow like thing. This is called anterior fat pad. This is called posterior fat pad. So closely when you watch here, you can see the fracture. You can see the fracture. So this is called fat pad sign. Fat pad sign is the most reliable radiological sign. Most reliable radiological sign. Then comes, you see here, normally when you see, I will draw and I will go. In the lateral aspect, when you see, normally you can see a structure which is the lower end of humerus, a teardrop like structure. Okay, this is the capitulum, teardrop like structure. In supracondylar fracture, the teardrop is disturbed. So a disturbed teardrop sign. Disturbed teardrop sign. Disturbed teardrop sign. Okay. Then you see here, this is the capitulum, this is the olecranon. I teach you, this is a concept based area, please focus your attention. This is the capitulum, this is your olecranon. This is your olecranon. When you see, there is a definitive gap between the capitulum and the olecranon. Yes or no? There is a definitive gap between the capitulum and the olecranon. You see here what has happened. The capitulum is overlapping the olecranon. There is no gap. Capitulum is overlapping the olecranon. I will draw and I will rub. You see here a crescent, this overlap of the capitulum of the olecranon results in a crescent like shadow, opacity. This is called crescent sign. This is called crescent sign. Okay, crescent sign. And the last sign is, this is the proximal end of the humerus. This is the proximal fragment of the fracture. This is the distal fragment. The end of the proximal fragment, when you see, the end is like a fish tail. End is like a fish tail. And this is called fishtail sign. This is called fishtail. All the 4 signs are very important. Surely they will ask you in image based. They will give an image and they will ask you to find out what is that. Very simple, fishtail sign. Dear friends, when you note one point very carefully, this is normal. Okay, this is lateral view. This teardrop fat pad sign is seen in lateral view. Teardrop sign is seen in lateral view. Crescent sign is seen in lateral view. Only sign that is seen in AP view is fishtail sign. Anteroposterior view of the elbow. Okay. Coming to treatment. Very simple. Okay. Sir. Okay. Yes. Okay. So, you see here, they are coming to treatment. Type 1, type 2, type 3. Okay. Type 1, type 2, type 3. Type 1, no surgery. Because it is a crack fracture in the supracondylar area. There is no displacement at all. So, when you flex the elbow to 110 degree, when the flex the elbow to 110 degree and give an above elbow POP cast, POP slab in 110 degree. When you flux it to 110 degree, the idea is why normally you will flux only to 90 and give an above elbow POP slab. In supracondylar fracture, you will flux it to 110 degree. Why I am flexing to 110 degree? Triceps will become very tight and triceps will go and support the fracture, so that fracture, it will buttress the fracture like a slab. So additional stability for healing. That is why you are flexing it to 110 degree. Okay. So this is the treatment of choice for type 1. Type 2, closed reduction, K-wire fixation. Type 3, open reduction, K-wire fixation. That's all. That's all. Okay. Marvelous. Now coming to complication, most common nerve that is involved in extension type of supracondylar fracture, anterior interosseous nerve. Most common nerve that is damaged in flexion type of supracondylar fracture, ulnar nerve. Most common vessel that is damaged is brachial artery. Brachial artery. Okay. Most common late complication, cubitus varus. Cubitus varus, which is nothing but a malunion. This is otherwise called gunstock deformity. Gunstock deformity. Asked question. And any injury around elbow, it is common for compartment syndrome and myositis ossificans. That completes supracondylar fracture. We will move on to another very, very important topic. Okay. Yes. Galeazzi fracture. Okay. The question which I had asked is good. Okay. Easy slang explanation to understand. Okay. Kaushik. Ashok. Yes, Ashok. Yes. So best treatment for Galeazzi fracture is POP. I am asking the question, best treatment. POP, open reduction with small plate, open reduction with long plate, intramedullary nails. Anybody try this answer? Many of you are answering and your answer is B. I will give you the right answer. This is the catch. Okay. Best treatment for Galeazzi fracture is open reduction, internal fixation with long plate. I will explain why long plate. The word long is very marvelous, man. Okay. Arpik, Rumi, Big Boss. Okay. Jaya, all of you have given the right answer. Good. Excellent. Okay. Excellent. Many have given the right answer. Open reduction, internal fixation with long plate. That word long is very important. I will explain why. Right. Now, in 2 minutes, we are going to finish the both important repeatedly asked MCQ area, Monteggia and Galeazzi. Monteggia's fracture, only one slide, man. Only one slide. We will finish both the topics. Monteggia, okay, Monteggia fracture is fracture proximal third ulna with radial head subluxation. Okay, it is the fracture proximal third ulna with dislocation of the radial head. This is the definition. Monteggia. Okay, Monteggia is more common in child, more common in children. Mechanism of injury is pronation. Mechanism of injury is pronation. In Monteggia, one should not forget McLaulin's line. McLaulin's line. McLaulin's line is otherwise called radiocapitular line. Radiocapitular line. Radiocapitular line. This is a very, very important thing. I am going to explain everything. Please wait. Monteggia fracture can be managed conservatively. Only needed they will do surgery, but POP is also tried. The most common nerve that is injured in Monteggia is posterior interosseous nerve, several times repeated MCQ. We all know posterior interosseous nerve is a branch of radial nerve. This is a branch of radial nerve. Okay. Anterior interosseous nerve is a branch of median nerve. Posterior interosseous nerve is a branch of radial nerve. Now I will explain this Monteggia's fracture. Please listen. Monteggia's fracture is otherwise called treacherous fracture. Treacherous means cheating. So Monteggia's fracture is called a cheating fracture. Which way that fracture can cheat us? Which way the fracture can cheat us? See, when you take an X-ray, fracture of the ulna is easily seen or noticed by everyone. Radial head dislocation, no, subluxation of the radial head, that we may miss, that may cheat us. That is why this Monteggia's fracture is otherwise called a cheating fracture or a treacherous fracture. To avoid this cheating, if you don't want to get cheated, you should follow McLaulin's line. McLaulin's line is otherwise called radiocapitular line. Very simple. You look at this X-ray. This is not an X-ray of Monteggia. This is an X-ray of Galeazzi. See, what is this radiocapitular? Radiocapitular. You just draw. This is radius. This is ulna. The middle axis of the radius. Draw a straight line. This will go and cut the capitulum. This portion of the humerus is called capitulum. So this will go and cut the capitulum. I will rub and again I will draw. You just see. When I draw a line along mid axis of the radius, this will go and cut the capitulum irrespective of position of the elbow. Whether I keep the elbow in flexion or I keep the elbow in extension, when I draw a line along the mid axis of the radius, this will go and cut the capitulum. When this cuts the capitulum, it says that radial head is at the normal position, is okay. See, this is your, you see dear friends, this is your radial head. This is your radial head, okay. This is your radial head. So this says it's okay. If it is a case of Monteggia, radial head is dislocated, no. So now I will try to draw a radiocapitular line. You see, this is your capitulum. In lateral view, this is your capitulum. I am drawing a line along mid axis of the radius. You see, it is not at all cutting the capitulum, is going and cutting shaft of the humerus. So this says that your radial head is guaranteed, it is subluxated, it is not in normal position. That is why if you don't want to get cheated by a Monteggia's fracture, McLaulin's line is very important. Okay. Have you all got my point? Am I clear? Please give me some thumbs up sign. Hello? Hello? Please give me some thumbs up sign if I am clear. Good. Thank you. Thank you. Thank you. Yes. Very good. Right. Now, the most common, it is Monteggia's fracture is more common in children than adult. And the most common nerve that is damaged is posterior interosseous nerve. So the patient will present to you with finger drop. Patient will present to you with finger drop like this. Patient will come with finger drop, thumb drop. Okay, posterior interosseous nerve. Right. If it is Galeazzi fracture is fracture distal third radius with distal radioulnar joint subluxation. 1 lakh time repeated MCQ man. Okay, very important. Fracture distal third radius with distal radioulnar joint subluxation. Right. It is more common in adult than children. It's more common in adult than children. And the classical clinical sign is called, this is clinical. The classical clinical sign is called piano key sign. What is that? Distal radioulnar joint is subluxated. So you just palpate the distal end of the ulna. Okay. The ulna will go down. When you release, it will come up. When you press, it will go down. When you release, it will come up. Like a piano key, keyboard key, piano key. So that is called piano key sign. And this Galeazzi fracture is otherwise called fracture of necessity. Fracture of necessity. Why it is called fracture of necessity? 100% surgery is necessary. The only treatment is surgery. You cannot manage conservatively. Monteggia, I said, can be managed conservatively. Scoliosis cannot be managed conservatively, only surgery, and the only treatment is long plate and screw. Long plate. Why? I will explain the concept why long plate. See, here there is a fracture. Here there is a distal radial ulnar joint subluxation. Only when I fix it with a long plate like this, screws like this, only when I fix it with a long plate, the distal radial ulnar joint subluxation will get corrected. When I put a small plate, distal radial ulnar joint subluxation is not corrected. That is why it is the only treatment is open reduction internal fixation with long plate and screw. Okay, and the common tendon that is damaged is extensor carpi ulnaris tendon. Which nerve is more commonly involved in Galeazzi fracture is highly controversial. There are 4 great books for ortho. 2 books are giving one answer, 2 books are giving a different answer. So we will pray to God that this question should not happen. Okay, that's why since it's a controversy, I had not typed. Okay, yes, ulnar nerve injury, aptly Shahinsha Gupta. Okay, so he has read our videos very thoroughly and he is answering. Okay, claps to you, Gupta. Okay, excellent, superb. Right, we will move on to the next topic. A 25-year-old male met with a violent road traffic accident. Perrectal examination done. A bony mass is felt. He is not able to move the lower limb. Probable diagnosis: pelvic fracture, fracture neck of femur, intratrochanteric fracture, central dislocation hip. Hello. Yes. Yeah, few answers are coming. I am expecting the right answer. Please read the question, clinical history very thoroughly. Yes, marvelous. Roni had given the right answer. Muhammad Ajmat. Okay. Chandu. Okay, so very good. Now everybody is coming with Puja. Everybody is coming with excellent answers. Marvelous. The right answer for this is central dislocation hip. You see here, violent road traffic accident, dear guys, and I said that you are doing perrectal examination. In perrectal examination, you are getting a bony mass, means it is head of the femur which has pierced the acetabulum and entering the pelvic cavity. Okay, so that condition is called central dislocation. In pelvic fracture, you won't palpate anything perrectally. Fracture neck of femur, intratrochanteric fracture, nothing is seen perrectally. Okay, only in center. Marvelous. Okay, so okay, Shahid Afridi, all of you have answered it correctly. Superb. Yes. Now coming to, we will finish dislocations of hip, an unavoidable topic for FMGE. In one slide, we are going to finish in 2 minutes. Posterior dislocation is the most common type. Most common type of hip dislocation is posterior. 1 lakh time repeated question. Most common injury is called dashboard injury. That is, patient is sitting in front seat, not wearing a seat belt. When you sit in a front seat, your hip is flexed to 90 degree, your knee is flexed to 90 degree. Collision happens, the knee joint goes and dashes against the dashboard. You will develop posterior dislocation hip, and that's the most common mechanism, and that's called dashboard injury. The classical attitude is the hip is flexed, adducted, internally rotated. Okay, this is very, very important. I don't know, this is the maximum number of times repeated question in your FMGE. Attitude of lower limb in posterior dislocation hip: flexion, adduction, internal rotation. Father is the mnemonic. Okay, father. Very good. All of you are answering. A marvelous, man. Father. Okay, so this is father. There is marked shortening of the affected limb. You see here, flexion, adduction, internal rotation. Father. Okay, and positive vascular sign of Norath. Positive vascular sign of Norath. Please focus your full attention. Many of you know this answer, but it's a revision for you because this is last resort revision. Okay, so nothing new I am teaching. It's only revision. Okay, you see here, vascular sign of Norath means what? I am palpating the femoral artery pulsation. When femoral artery pulsation is not felt, it is called a positive vascular sign of North. When I put the patient in supine position, if I keep my thumb in the mid-inguinal point, I should palpate the femoral artery pulsation. That is normal. If I am not able to feel the femoral artery pulsation, that is called the vascular sign of North, positive vascular sign of North. In posterior dislocation hip, what happens? The neck and head is slipped out of the acetabulum. It has gone posteriorly. Underlying bony support is not there. See, why I am able to palpate the arterial pulse easily? Underlying the vessel, there is some bony tissue. That is, your head and neck is there. That is why when I press, easily the vessel is palpated. That is why you are able to palpate the radial artery easily. Why I am able to palpate the radial artery easily? Underlying radial styloid bone is there. If that radial bone is not there, however much I do, I can't palpate the radial artery easily. So the underlying bony support is lost in posterior dislocation. So you will get positive vascular sign of North. Positive vascular sign of North. What are all the conditions that causes positive vascular sign of North? These are the DD. Posterior dislocation hip, congenital dislocation hip in a child, fracture neck of femur, avascular necrosis head of the femur. Head of the femur is gone for avascular necrosis, absorbed. Tom Smith's arthritis, that is septic arthritis of the hip that is happening in a child. Girdle stones excision arthroplasty, which is done for tuberculosis, Okay. So these are the DDs. Now you see, this is posterior dislocation hip. Anterior dislocation hip usually happens in crash landing, air crash injury. The classical attitude of anterior dislocation is flexion, abduction, external rotation. Flexion, abduction, external rotation. Faber, flexion, abduction, external rotation. Sir, marvelous you are. And okay, thank you, Dr. PKS. Okay, yes, super. Right, super. So thank you for your this thing, compliment. Right. You see here, see that clinically it is, see, that's called Faber, flexion, abduction, external rotation. Classically there is limb lengthening, and here vascular sign of North won't be there because head is still, the bony support is there. So femoral artery pulsation is felt. The nerve that is most commonly injured in posterior dislocation hip, is sciatic. Sciatic nerve. So the patient will present you with foot drop. The nerve that is commonly involved in anterior dislocation hip is femoral nerve. It is femoral nerve. Okay. Femoral nerve is involved. How there will be presentation? Quadriceps wasting. Okay. So this is posterior and anterior. Central dislocation hip, I said attitude of the lower limb is not at all altered, because what is central dislocation? Acetabulum, floor of the acetabulum is fractured. Head of the humerus enters the acetabulum into the pelvic cavity. That is called central dislocation hip. Perrectally, when you do perrectal examination, head of the humerus is palpable easily. That is central dislocation of the hip. Okay. So that's all in hip dislocation. Right. And yes. Dr. Arun Prasad, I will do. Okay. Yes. Arun Prasad, what you said, it's urgently needed. What is the problem, Arun? What do you want me to consult? Arun, you just type and tell. Okay, you want to meet urgently means what is the problem? You just type. At the end I will contact you. You see, this is central dislocation. Okay, and one request from Dr. Akhilesh. Dr. Soy, please discuss about tendo Achilles injury as it is asked in INI-CET. You want me to tell about tendo Achilles injury? Shall I will finish this dislocation hip and shall I tell? Soy, I will tell. You see here, this X-ray, you see, Shenton's line, very, very important thing, Shenton's line. Asked question, Shenton's line. What is Shenton's line? This is superior pubic rami. I am drawing a line along the inferior border of the superior pubic rami. It forms a smooth curve along the head, the neck, and it comes like this. This line is called Shenton's line. This is normal. In case of anterior dislocation hip, in case of posterior dislocation hip, in case of central dislocation hip, Shenton's line is broken. In neck of femur also it is broken. You see, I am trying to see here, this is a case of posterior dislocation, anterior dislocation, central dislocation. I am trying to draw a Shenton's line. Superior pubic ramus, I am drawing a line along the inferior border of the superior pubic rami. You see, the line is broken. I am not able to complete like this. Line is broken. This is the normal side. This is normal side. I am drawing a Shenton's line. You see here, smooth line. I am able to get. This is affected anterior dislocation hip. You see, I am able to draw a line. The line is broken. This is normal side. I am drawing a line. You are able to see this is Shenton's line. This is central dislocation. I am trying to draw a line. Line is broken. Okay, Shenton's line is broken. Shenton's line is broken. Okay, excellent. Now, coming to the treatment, dislocation hip is an orthopedic emergency. Usually, closed reduction tried under anesthesia. Ideally, it should be done within 6 to 12 hours. Why it should be done within 6 to 12 hours? If anyone answers this question correctly, okay, I'll give a big clap to you with your name. You'll be appreciated. Okay, I will count because there is no time. Quickly should answer. Why it should be reduced immediately? Orthopedic emergency. In shoulder dislocation, I had never used the word orthopedic emergency. In hip dislocation, I am using the word orthopedic emergency. Done immediately. Why? Oh, hey, oh my God. Okay, Dr. Moshin. Yeah, just like that you are answering. Okay, just like that you are answering. Many of you have answered it. You FMGE guys, you are rocking, man. Marvelous. Okay, you see, because there is a vessel called artery of ligamentum teres. Artery of ligamentum teres, which attaches in the head of the femur, in the fovea. That ligament carries a blood vessel, that's called foveal vessel. When hip dislocation happens, when you don't reduce, permanent arterial damage can happen, permanent ischemia can happen to head of the femur, and head of the femur may go for avascular necrosis. That is the reason. Superb. Sir, I have confusion in femoral head injury fracture as when we do totally people open reduction, young people. Yes, that okay, very good. Okay, easy. Okay, marvelous. Okay, superb, excellent. Right now, the reduction techniques that are available: Stimson's gravity, not very useful. Classical Watson-Jones method. This is the best method. It was followed. Now, recently, this is a better method. This is a better method. I will tell you. These two you can forget. Okay, I will tell you what is that. Put the patient. Okay, put the patient. Okay, yes. Okay, put the patient. So, how to do this classical Watson-Jones method, which was the first successful method for, first scientific successful method for posterior dislocation hip. How to do that? Put the patient in the ground in supine position, give muscle relaxant, anesthesia, everything, flex the hip to 90 degree, flex the knee joint to 90 degree. One of your assistant will press the pelvic, both the pelvis, and give counter traction. You are gradually lifting up. That is called the classical Watson-Jones method. Classical Watson-Jones method. With gradual upward pull, when you do internal rotation and the external rotation, that is called Alice. They say this is better than Watson-Jones method, but they won't ask you how to do. These names are important. These are the methods. Coming to complications of dislocation hip, most common nerve that is involved is sciatic nerve in posterior dislocation, that too common peroneal branch. Most common vessel that is damaged is superior gluteal artery. Very important. And it goes for myositis ossificans, avascular necrosis, head of the femur, secondary osteoarthritis, recurrent dislocation. Don't forget fracture neck of femur and dislocation hip. Notoriously, they can go for thromboembolism. They can go for thromboembolism. Okay, chances are there. What is the chance? 40% thromboembolism. Right. Before going to the next question, Dr. Soy has asked a question about tendo Achilles injury, because they said they had asked this in INI-CET. They asked a question. So you guys and girls, you want me to discuss about tendo Achilles now? If you really want me to discuss, give me some thumbs up, some sign, so that in 2 minutes I'll finish tendo Achilles. We don't have a separate slide, please. Yes, please. Okay, right, good. Okay, yes. Tendo Achilles is the strongest tendon of our human body. You know where it is. It comes, the posterior aspect of the tarsal tunnel gets attached to the calcaneum, tendo Achilles. Commonest mode of injury, for example, you just remember, just imagine, this is my foot, this is my leg, this is my calf muscle, this is tendo Achilles. Okay. So, the most common mechanism of tendo Achilles cut or injury is, the textbook Bailey and Love says, surgery textbook, closet injury. Closet injury. When you slip in the closet, Indian toilet, when you slip in that, sudden unexpected high dorsiflexion of the foot, tendo Achilles is gone. This is the most common mode of injury, closet injury. Okay, nowadays everything Western toilet, so that's not happening. Closet injury. When this happens, how to clinically diagnose tendo Achilles injury? One should not forget what is called a Thompson's test. Thompson's test. Thompson's test. Okay. Okay. So Thompson's test. Okay. Thompson's test. What is that? You please imagine, this is my leg, calf muscle. This is tendo Achilles. This is my foot. I am putting the patient in prone position, flexing the knee joint to 90 degree like this. When I squeeze the calf muscle, my foot should go for plantar flexion. Yes or no? This is normal. If tendo Achilles is cut, when I squeeze the calf muscle, there is no action of the foot. This is called a positive Thompson's sign. And how to treat tendo Achilles injury? Tendo Achilles injury can be treated only surgically, because the tendon is avascular. However much you immobilize, that won't heal. You have to suture it. The suture technique or the surgical technique or treatment of choice for tendo Achilles injury is called Kessler's method. Kessler. Kessler's method. Kessler's method, it's a method of suturing. What is that? You just imagine, this is your proximal fragment of the tendo Achilles. This is the distal fragment of the tendo Achilles. Okay, I am taking a suture from here. The suture material is 1-proline, which is a non-absorbable thick suture material. I am taking this, going like this and completing the stitch here. This is called Kessler's stitch. That is called Kessler's stitch. So don't forget the classical clinical sign and okay, yes. So this is about tendo Achilles. We'll move on to the next topic. A 30-year-old male met with an accident. X-ray shows the following image. Best treatment would be. Look at the X-ray. 4 treatment options are there. Okay. Yes, Sai. Thank you, Sai. So the 30-year-old male met with an accident. X-ray shows the following image. Best treatment would be. You see here, this X. What is the best treatment? Yes, Tara has given the right answer. Ajay Dar. Afridin Shri, yes. AJ Pulse. Okay, marvelous man. Many of you have given the right answer. The right answer is tension band wiring. The right answer is tension band wiring. Okay. So this is a case of fracture patella. Why I am using the word tension band wiring? When I see this X-ray, this is skyline view. This is skyline view or axial view, skyline view. I am seeing a patellar fracture, and the patellar fracture, it is displaced. It is, you see the gap is more than 2. More than 2. Okay, so it is displaced. So a displaced transverse fracture patella, treatment of choice is tension band wiring. Okay, if it is an undisplaced fracture, very good. Merchant view, marvelous. Okay, Merchant and Rice. Akhilesh Gupta is asking a question. Sir, skyline and rising sun view are same? No, Akhilesh. I am going to explain. Both are different, Akhilesh. I will explain. Okay, both are different. I am going to explain, Akhilesh. You see here, patella, most common mechanism is indirect injury. What is that indirect injury? Violent contraction of the quadriceps muscle. Violent contraction of the quadriceps muscle. For example, a football player is running. Suddenly he is trying to stop. Violent contraction of quadriceps can happen. You are walking on the roadside. A big pit is there. You have not noticed. You are tumbled, stepped inside the pit. Violent contraction of quadriceps can happen. That is the most common mechanism which causes transverse fracture. That is why the most common form of fracture pattern of patella is transverse. Okay. So you see here, this is the most, and when you just palpate, there is a palpable gap. This you can't try. Patient is having severe pain. This is an operation theatre after spinal anesthesia. Before surgery, in all transverse fracture patella, to my undergraduate students, after giving spinal, patient won't feel pain, no? So I will insinuate the finger. I'll ask them to insinuate the finger and palpate the gap in my medical college. Okay, so this is the classical palpable gap is a very classical sign of transverse fracture patella. So the fracture is into two, displaced, undisplaced. When the displacement is more than 2 millimeter, that is called displaced. When displacement is less than 2 millimeter, is called undisplaced. Most common type is transverse. This is the next common type. Next common type is comminuted. Other two you can forget. Okay. You see, now coming to the X-ray views, Akhilesh, I am coming to your answer. X-ray view, two views are available. This view is called skyline view, otherwise called axial view, otherwise called merchant view. Three names are there, and this is the view of choice. What is the difference? Akhilesh, please carefully follow me. See here, the patient is in prone position. This is the cassette. This is the film. Cassette is here. Beam is passing from here. Beam is passing from here. Okay. When you see, the knee joint is flexed to 45 degree only. The knee joint is flexed to 45 degree only. When you flex the knee joint to 45 degree, you will get a view like this, and this is called skyline view or axial view or merchant, the person who described it. Instead of 45 degree flexion, when you flex it to 110 degree, the image will appear like this. This is called sunrise view. This is called sunrise view. This is also a good view, but I have used the term, this is the view of choice. This is the view of choice. Why? Because when I flex to 45 degree, pain will be less. When I flex to 110 degree, pain will be more. Already he is having a transverse fracture patella. How painful it will be. So it will hurt the patient less when you flex it to 45. This is more than enough. So this has become view of choice, best view. Okay, coming to treatment. When the displacement is less than 2 millimeter, that is called undisplaced, and the best management is cylinder cast. You see, from middle of the thigh up to the ankle, only knee joint is immobilized. Ankle and hip are free. This is called cylinder cast. When it is displaced fracture, when the gap is more than 2 millimeter, surgery is the treatment of choice, and the best treatment, you see, like I put the SS wire, the form of figure of 8, it is there, form of figure of 8. This is called Martin's circumferential tension band wiring. This is Martin's circumferential tension band wiring, which is the gold standard treatment. If other way, very rare possibility, when the patella is totally shattered, totally comminuted, you cannot reconstruct. What is the only treatment that is available? Patelectomy. For severely comminuted fracture patella, the best treatment is patelectomy. When you do patelectomy, what is the only complication? The only complication is called extensor lag. Nothing, it will not, okay, it will not patelectomy, yes, very good. See, patelectomy is, it won't do much harm to the patient. Patient can do cycling, jogging, normally climbing stairs, squatting, sitting cross-legged, everything is possible. Last 10-degree extension of the knee won't come, because last 10-degree extension of the knee won't come because that pulley is lost, patella is not there. That is called extensor lag. What is extensor lag? Last 10-degree extension is not possible. That is the only complication of patelectomy. You see here, this leg, okay, he is able to extend fully. Here, last 10-degree extension is not possible. The other leg. This is called extensor lag. That's the only complication. We will move on to the next important question. All are components of unhappy triad of knee except. Several times repeated question. Yes. Hello. All are components of unhappy triad of knee except. Come on. Please answer, guys. You know the answer. It's a revision. Hello, come on. This is called unhappy triad. This other is called terrible triad of the knee. Terrible triad. Marvelous, man. Oh, superb. All, a majority have answered excellently. Oh, right. Selfie power is, he's criticizing me. 1 lakh time asked question. Yes, that's my favorite word. Right? Good. All are components of unhappy triad of knee except lateral collateral ligament injury. Lateral collateral ligament injury. Okay. Yes. Cell film prober. Yes. 1 lakh time repeated question. Yes. Right. You see here. Anterocruciate ligament injury. Mechanism of isolated ACL injury is quick deceleration. This is the main thing. Most common mechanism of ACL injury is quick deceleration. What do you mean by that? A football player is running. Suddenly somebody has come on the way. Suddenly, unexpectedly, very quickly he wants to decelerate his force. Okay, ACL will be gone. That's the most common. Otherwise, foot flux to the ground, twisting, rotation of the knee joint. That is the second common mechanism. Right? And when the knee joint is hit from the side, anterocruciate ligament is gone, medial menisci is gone, medial collateral is gone. This is called unhappy triad of O'Donoghue. The correct pronunciation is O'Donoghue. Okay, yes. Okay, so it is anterocruciate ligament when this is called O'Donoghue. Sir, you taught so less in version 11. Version 11 is what you are talking about, rapid revision. Rapid revision. Yes. How this? Okay, so yes, rapid revision. That is rapid revision, man. The full content is version X. You see, when the knee is hit from side, ACL is gone, medial meniscus is gone, medial collateral is gone. That is called terrible triad of knee. He is an Ireland surgeon. And the pronunciation is O'Donoghue. Okay. So, what is quick, sir? What is, sir? What is that? Intercondyle or not? What, sir? How deceleration? Okay. See how deceleration. See, anterocruciate ligament. No, it prevents the slippage of the lower femur to the tibia. Okay. So when a patient is running very fast, unexpectedly slowing down, no, what happens? There is an untoward pull of the tibia and the femur like this, and the anterocruciate ligament is gone. That is why quick deceleration, cutting actions. So these are the common modes, right? Now coming to clinical feature. See, dear friends, only one point I want. Okay, so only one point is gem. Okay, so see this coming to the clinical feature, only one point I want you to stress. This is a concept based area, dear friends, and the MCQ can be repeated. It can be repeated, and it has been asked several times. You please focus your full attention. You see here, a patient, see, knee joint ligament injury, internal derangement knee can happen. The two common injuries that are possible are cruciate ligament, menisci. Clinically, how to differentiate cruciate is gone or menisci is gone? Obviously, when you do an MRI, that is going to tell you clinically how you are going to differentiate. This is the question in NEET they had asked several times. High chance it may come in FMGE now. Please focus your full attention. A patient, a football player is playing. He had some injury, had fallen down. Immediately he couldn't get up. After he had fallen down, he is not able to get up. Immediate swelling happens. 99% it should be a case of cruciate, anterocruciate ligament injury. Other way around, patient had fallen down, he got up, he continued to play. After 24 hours, he is developing pain and swelling. It is menisci is gone. Okay, this is the point I want to okay, so this is the point I want you to remember. This is the point I want you to remember. Okay, swelling and pain comes little later. Most probably it is menisci. Swelling and pain coming immediately, it is cruciate. Please have this in your mind. Highly expected question in FMGE. They will give a history like this. 22-year-old football player fall in the ground. He got up. He continued to play. Next day, he developed pain and swelling in the knee joint. Most probable menisci, medial menisci. Fallen down, couldn't get up. Immediate pain, immediate swelling. Somebody has to assist him for, he can't walk at all. Cruciate, anterocruciate. Okay. The commonest menisci that is injured is medial menisci. Commonest cruciate that is damaged is anterocruciate. Posterior cruciate ligament injury is rare. Lateral meniscal injury is rare. Okay. Yes. Clinically, one should not forget anterior Droyer's test and Latchman test. Anterior Droyer's test is make the patient lie down in supine position, flex the knee joint to 90 degree, sit over the foot like this, just do, gives an anterior translation, This is called anterior Droyer's test. Latchman test is, instead of flexing to 90 degree, flex only to 30 degree, flex only to 30 degree and do like this. That's called Latchman. Okay. Much of technical is not needed. In anterior Droyer's you are flexing to 90. In Latchman you are flexing only to 30. The question they are asking is, which is a better test, clinical test? Anterior Droyer's or Latchman? Which is more reliable? Always the gold standard test, the best test for anterocruciate ligament is Latchman. This is the test of choice. Gold standard. Okay. This is the gold standard. There is no doubt. This is the gold standard. Okay. Yes. Okay. Right. Right. Okay. So this is Latchman's, right? So why Latchman is superior to anterior drawers? Why Latchman is superior to anterior drawers? In anterior drawers, you are flexing the knee joint to 90 degree. You are flexing the knee joint to 90 degree. When you flex the knee joint to 90 degree, posterior horn of medial menisci may come and hold the tibia. Posterior horn of medial menisci can come and hold the tibia, and when you try to do an anterior, sometimes the posterior horn may hold the tibia. It will give a false negative anterior dryas. But when you flex the knee only to 30 degree, that phenomena cannot happen. So guaranteed, if the anterior cruciate ligament is gone, it will show you positive. This is called doorstep phenomena. This is called doorstep phenomena. This is called doorstep phenomena. Okay, this is called doorstep phenomena. Doorstep phenomena is there in anterior drawers. Doorstep phenomena is not there in Latchman's. Okay, good. Yes. Okay. Marvelous. Okay, Shahinshah Gupta, all of you, yes sir, yes, you have answered your doorstep phenomena. That very good. Good. Coming to investigation, we all know that investigation of choice is MRI. We all know that investigation of choice of cruciate ligament is MRI. In X-ray, this was asked once. Okay, this was asked once in image based. You see here, there is avulsion of the tibial spine, spinous process of the tibia. There is avulsion of spinous process of the tibial eminence fracture. Okay, I will erase this. You zoom and see. This is a radiological sign of ACL injury. This is a radiological sign of ACL injury. Here, when you see here, this is lateral tibial condyle. Lateral tibial condyle, you can see a chip fracture. Lateral tibial condyle, there is a chip fracture, and this is called Segond fracture. They had asked this radiological sign. They have not asked this radiological sign so far. So highly expected question, Segond fracture. Now coming to investigation of choice, it is MRI. Okay, yes, investigation of choice, it is MRI is the investigation of choice. And when you see in the MRI, you see this blue color structure. This is your anterocruciate ligament. This is your posterior cruciate. Normally it is seen. This will be in MRI. You can see discontinuity of the ACL. Now coming to treatment, non-surgical management, surgical management. Non-surgically, if the patient is unfit for surgery, not willing for surgery, what is this? It is not the best treatment. What option are possible? I have to strengthen the hamstrings. I have to strengthen the hamstrings, and that is called closed chain. That is called closed chain. Right? Surgical management, if bony avulsion present, right? Avulse fragment is fixed with a suture. The best treatment or treatment of choice is reconstruction of ACL. This is the gold standard. This is the gold standard. This is the treatment of choice. Reconstruction of the anterocruciate ligament. How can I reconstruct the anterocruciate ligament? I will take semitendinosus gracilis muscle graft. This STG, this is the first option. This is the best option. Okay. Second option is bone patella tendon bone graft, BTB. Okay. Yes. So the best treatment for ACL injury, if they ask in exam, very simple. ACL reconstruction using semitendinosus gracilis graft. Okay. Semitendinosus gracilis graft. Right. Prerequisites. When will you do ACL reconstruction? You should give adequate. It is not an emergency. Not necessarily should do on day one. First of all, patient should have regained full range of movement of the knee. I used to do after 2 weeks. Okay, 2 weeks. I will give time, 2 weeks. Hemarthrosis should settle. There should not be any hemarthrosis. When hemarthrosis is there, when you do arthroscopy, more prone for infection. Don't do that. Patient should have gained good quadriceps strength. When ACL is torn, you explain to them, we have to give enough time. The swelling should subside. You should flex and extend freely. Then when we do a reconstruction, the outcome, the result is excellent. Now, coming to post-cruciate ligament injury, not very rare. The point I want to tell is Godfrey's sign. Godfrey's sign is otherwise called gravity sign. Godfrey's sign is otherwise called gravity sign. What is that? Make the patient lie down in supine position, hip the knee joint to 90 degree, flex the knee joint to 90 degree. You see here, in this position, when you see tangentially, the tibial tuberosity will sag. The tibial tuberosity here, it will sag. This is called a sag sign, a gravity sign. The test is named after Godfrey. I want you to remember this because they have not asked in the exam so far. Many times asked question is only anterior dryas and Latchman. Post-cruciate ligament they have not asked. So focus here. This is expected. This is expected. Okay. Yes. Coming to investigation, MRI. That's okay. Right. Yes. Now you try to answer most common site of pot spine. Next topic. Most common site of pot spine. Yes. Very good. Very good. Yes. Dorsolumbar, paradiscal. Okay. Okay. Yes. Marvelous. Okay. Many of you have given the right answer. D. Yes. Uttam Muhammad. Utmed moments. Good. Many of you have given the right answer. The most common site of skeletal TB, that spot spine, is D12. It is D12 because books have explained D12 L1 junction. When you read aptly, the most common site of spot spine is D12. The explanation they give, this is the maximum weight bearing vertebra. There is a maximum weight bearing vertebra. Weight bearing vertebra. Okay, this is the maximum weight bearing vertebra. Okay, good. D12. Many of you have answered it correctly. Excellent, man. Yes. Yes. Now, skeletal tuberculosis, the most common site of skeletal tuberculosis, number 1 is spine. First common site, pot spine. Hip, second common site. Second common site is hip. Third common site is knee. First common site is hip, spine, that is D12. Second common site is hip. Third common site is knee. Least common site of skeletal tuberculosis is mandible and temporomandibular joint. They have not asked this so far. Most common site, several times they had repeated. Least common type they have not asked. Mandible, temporomandibular joint. Highest incident in young adults, not in elderly or children. You see, young adults, commonest fracture in young adults, scaphoid. Okay. Uncommon in old age. In our country, human type of tubercle bacilli is invariably the causative agent, because there are two types of skeletal, there are two types of tubercle bacilli. One is human type, another is bovine type. In our country, human type is the most common type. Bovine type, in our country, in Europe only it is common, Western country only it is common, because we pasteurize the milk and we drink. We won't drink a raw milk. So bovine tuberculosis is uncommon in India. Most common route of spread is hematogenous. Infection first affects the epiphyseal cartilage, that is okay. You see here, X-ray of affected thing shows washed out appearance. Very important MCQ. They can ask in ortho and in radiology. What do you mean by washed out appearance? Because it causes localized osteoporosis. So you feel as if the bone density comes down. You feel the bone is being washed. So it's called a washed out. Localized osteoporosis, very characteristic, and it is called washed out appearance. See, periarticular osteoporosis and localized osteoporosis. See, dear friends, I want to tell one more MCQ here. Whenever a question periarticular osteoporosis or localized osteoporosis comes, there are two DDs for this. One is tuberculosis, another is rheumatoid arthritis. Whenever in X-ray, okay, yes, whenever in X-ray they ask a question, periarticular osteoporosis is seen in. One DD is tuberculosis, skeletal tuberculosis, another is your rheumatoid arthritis, right? And you see here, don't forget the word Femistus triad. Femistus triad, whenever a word comes, the classical radiological triad of skeletal tuberculosis, okay, skeletal TB, it is Femistus triad. Femistus triad, number one, periarticular osteoporosis. So this is the articulating surface, periarticular. Around this, whenever there is an osteoporosis, it's called periarticular osteoporosis. Number two, peripherally located bony erosion. You see here, this something has bitten and eaten away. It shows like that, no? Right? So they are called, you concentrate on this side, this and here. I will rub. Okay. So this is called peripherally located bony erosion. Number three, joint space narrowing. Look at here, totally the joint space is very much narrowed. So joint space narrowing. So periarticular, this triad is called Femistus triad. Whenever a question Femistus triad is seen in skeletal tuberculosis, all are components of Femistus triad except they may ask a question. This may be a new question to you, and generally the drugs that are used for skeletal tuberculosis, first line drugs are INI-CET, rifampicin, ethambutol, streptomycin, pyrazinamide. Okay, and you know the dose. Coming to second line drugs, thioacetazone, paraamino-salicylic acid, ethylamide, cycloserine. Right? These are the second line drugs. For skeletal tuberculosis, WHO recommends category 1 treatment, that is 2 months. It is INI-CET, rifampicin, pyrazinamide, ethambutol plus 4 months INI-CET and rifampicin. 4 months INI-CET and rifampicin. So this is the treatment. This is called CAT 1, category 1 treatment recommended by WHO. Right. Coming to port spine, usually clinical symptom is painful, stiff back. Classical night cries is very characteristic. See, what is night cries? When patient goes to the bed, totally he is pain free. He will start sleeping. In deep sleep, especially during REM phase. Okay, rapid eye movement. Especially during rapid eye movement, REM phase. Okay, what happens? The muscle gets relaxed in REM phase. Sudden pain comes, patient will get up and he starts crying. That is called night cries. Night cries means during onset of sleep, patient is not having pain. He is sleeping deeply. Sudden pain comes which disturb his sleep. That is called a night cries. And the first deformity to occur is called loss of normal cervical and lumbar lordosis. Look at this diagram. Patient is standing in a wall. Normally, I am able to see a cervical lordosis, a lumbar lordosis. This is normal. When a patient stands, the normal cervical lordosis and lumbar lordosis is lost. Totally, you are not able to insinuate your finger in the lumbar and the cervical area. This says that patient has developed paraspinal muscle spasm. Whenever paraspinal muscle spasm happens, the normal lordosis is lost. That is the first sign. Why I am stressing this point again and again, dear friends? Why I am stressing this point again and again, dear friends? Because many of you, whenever they ask us tuberculosis, immediately gibbous will come to your mind. Gibbous is the second deformity. In clinical history, if they say that most common deformity to happen in the choice, loss of normal cervical lumbar lordosis is there, that is the right answer. Second deformity to happen is gibbous. Gibbous is in the thoracic vertebra, 2 or 3 vertebrae, the vertebral body collapses and all the spinous process join together, form a hump-like thing. You are able to see here. This is called gibbous. That is the second deformity, gibbous. Okay, and coming to the X-ray, the earliest sign already I told you, radiolucency, loss of definition of the plate margins. And coming to CT scan remains preferred imaging, not investigation of choice. Best investigation is MRI for pot spine. For pot spine, if they ask best investigation, MRI is there in the choice. You should straight away go for MRI. Because among the various types of imaging modalities, MRI has the ability to diagnose the disease earlier and more accurately. Point number 1. And it is useful in assessing the spinal nerve root compression. CT scan cannot assess spinal nerve root compression. X-ray cannot assess spinal nerve root compression. Only MRI will tell you in the earliest way whether the spine nerve root is compressed or not. So this is the investigation of choice. This is the MRI is the investigation of choice. Of course, when you do a biopsy, when you take a biopsy, put it under a histopathological slide and see Langerhans giant cell. Langerhans giant cell. That is 100% confirmative. But that's an invasive investigation, no? Biopsy is invasive investigation. Okay. MRI is non-invasive. So this is the best investigation for pot spine. Coming to treatment, one should not. Yes, what will be the answer if asked for preferred investigation and confirmatory? Okay, yes, yes. Okay, yes, you see here, see, you asked a question, you are asking a question, okay, Islam. Yes, you have asked a question. What is the what is the answer if asked? Preferred investigation, confirmatory. Okay. If they are preferred investigation, it is MRI. Preferred investigation, it is MRI. 100% confirmed when they had specifically given percutaneous CT guided biopsy, then you can go for biopsy. Okay. So it is preferred investigation is MRI. Right. Coming to treatment, SM Tully's middle path regime. SM Tully's middle path regime. Okay, so this is the accepted treatment throughout the world. Professor Tully is our Indian professor, but this is accepted throughout the world. First, you give rest in a hard bed or POP bed. Hard bed or a POP bed. Then start the patient on, yes, thank you, Islam, thank you. Yes, so it is, then you start the patient on ATT. Followed every 3 months with X-ray and ESR. See, what is the very aim of Professor Tully's middle path regime? Middle path regime means unnecessarily don't go for surgery. Unnecessarily don't go for a spine surgery. Okay, try to manage conservatively. Gradual mobilization is done. Patient with no neurological deficit helps too. When surgery is indicated, only when there is no recovery after fair trial or worsening neurological status. Only when there is no recovery after fair trial, you had waited for 6 months, there is no improvement, then you have to go for surgery. Indications for surgery, this is the most important slide, dear friends. You should categorize indications for surgery with neurological deficit, without neurological deficit. You are getting one patient, okay, you are getting one patient, he is a pot spine case, he is coming to you with neurological deficit. When he comes, you had examined, there is neurological deficit. When will you, what is the indication for surgery? No recovery after 3 to 4 weeks of drugs, ATT. Paraplegia getting worse in spite of medical treatment. spastic paraplegia with severe uncontrolled spasm of leg. Patient is coming to you, he is having spasm of the leg, uncontrolled spasm of the leg. Don't try medical treatment. You just go on day one, go for surgery. This is, all these points are asked, very important. Patient is coming, another patient is coming to you, he is a part spine, he is not having any neurological deficit, but you should go for surgery. Where? Extensive paravertebral abscess. Excessive paravertebral abscess. In the history, when they say directly you should go for surgery, because paravertebral abscess, ATT, anti-tuberculosis drug, won't reach that site. It won't reach the site. Okay. Now, coming to the operations that are available, the best procedure alone I will tell, anterolateral decompression. This is the treatment of choice. Best surgical procedure for pot spine is anterolateral decompression. Now coming to tuberculosis of hip, one should not forget this stage. Repeat, like your dislocation hip. In dislocation hip, they will give an image. They will ask you, what is this? Fabr father, we had seen, no, like that. They will give this and they will ask you what stage. Stage of synovitis, stage of early arthritis, stage of late arthritis, stage of pathological dislocation. 4 stages are there. Okay. So stage of synovitis, there is irritable hip, severe pain will be there. Look at the image, flexion, abduction, external rotation. Flexion, abduction, external rotation. Faber, like your anterior dislocation hip. Like your anterior dislocation hip. There is apparent lengthening. Terminal range of movement is restricted only by 25%. Only by 25%. Stage 2, stage of early arthritis, articular cartilage damage and flexion, adduction, internal rotation. Flexion, adduction, internal rotation. And range of movement is restricted only by 50%. By 50%. Late arthritis, same thing, marked flexion like your PDH, almost like a posterior dislocation hip. Okay, true shortening will be there. And stage of pathological dislocation, totally the hip has dislocated. Here I want you to tell the word traveling acetabulum. Traveling acetabulum. You see here, totally everything is damaged and the synovium will go for a repeated dislocation. Synovium will go for what is called a hourglass like constriction, right? From the hourglass constriction, what happens? The head from the original acetabulum will go reside in the pseudo acetabulum, again come back to original acetabulum. Only the head is traveling, but the term is traveling acetabulum. That's a misnomer. Okay, in the textbook that says traveling acetabulum, the word is a misnomer, acetabulum. So they won't ask for the explanation, but they will tell you traveling acetabulum is there. So see, the thing is, whenever they ask a question traveling acetabulum, it is stage 4. It is stage 4 Ponde's classification of tuberculosis of the hip. The only place this word traveling acetabulum comes in, tuberculosis of the hip. Yes. Now coming to another important point in the stage 4 is protrusio acetabuli. You see here, normally the acetabulum is here intact. You see this acetabulum is protruding, is damaged and the head is entering the pelvic cavity. That's called protrusio acetabuli. Now coming to the stages, the treatment is very important. Stage of synovitis, treatment is conservative. Treatment is conservative, no surgery. Okay, it is conservative, no surgery. Give rest, give skin traction, ATT, category 1 ATT, stage 1. Stage of arthritis, you should start the patient on ATT, non-weight bearing, unresponsive case, you have to go open the joint, do a synovectomy and joint cleaning, that is joint debridement. Stage of pathological dislocation, you can't do anything, you have to go for girdle stones excision arthroplasty. Girdle stones excision arthroplasty means I am excising the neck and the head. Okay. Then when the TB settles down, tuberculosis settles down after medical management, proper treatment is reconstruction of the hip by total hip replacement, THR, total hip replacement. So in nutshell, best treatment for synovitis, TB, hip synovitis, conservative. Best treatment for stage of arthritis is ATT plus joint debridement. Best treatment for stage of pathological dislocation is excision arthroplasty with total hip replacement. That's all. Very simple. Okay. Now coming to tuberculosis of the knee joint. Knee is the third common site. Knee is the third common site. Initial focus may be synovium, and in knee don't forget triple deformity. Triple deformity. Three things are happening, dear friends. Focus your full attention. Three things are happening. Triple deformity. Three things. What are they? Tibia is dislocated posteriorly, shifted laterally, rotated externally. Triple deformity. Tibia is shifted posteriorly, shifted laterally, rotated externally. That is called triple deformity. All these things are happening because of tightening of the iliotibial band. So whenever a triple deformity, a word triple deformity comes in ortho, two differential diagnoses, dear friends. One is TB knee, another is polio. There are two causes for triple deformity. Okay, two causes for triple deformity. One is tuberculosis knee, another is poliomyelitis. Now coming to the next important question. Osteogenic sarcoma commonly metastasis to which organ? Osteogenic sarcoma commonly metastasis to? Yes. Please answer. Osteogenic sarcoma commonly metastasis to? Yes. Muhammad has answered correctly. Oh, superb. Yogesh Dixit. Yes. Prajwa. Very good. Many of you have answered correctly. Osteogenic sarcoma, the notorious problem with osteogenic sarcoma, it metastasis to lung very fast by blood. Okay, hematogenous. Okay, hematogenous. Osteogenic sarcoma, again there is no question paper without the topic osteogenic sarcoma. See certain most commons we have to discuss here. Look at the first line. Most common non-hematological primary malignant bone tumor. Each and every word is important. If they ask a question, most common primary malignant bone tumor, the answer is not osteogenic sarcoma. The answer is multiple myeloma. Most common, see please, these most common, this is last resort revision. We are revising. We are only revising. We are not reading for the first time. Focus your full attention. If they ask one time, I will tell you, please focus your full attention. Most common bone tumor, if they ask a question, most common bone tumor, secondaries. Most common primary malignant bone tumor, multiple myeloma. Most common primary benign bone tumor, osteochondroma. Most common primary non-hematological malignant bone tumor, osteogenic sarcoma. Okay, please one more time. Okay, yes, one more time I will tell you most common bone tumor, secondaries, most common primary malignant bone tumor, multiple myeloma, most common primary benign bone tumor, osteochondroma, most common primary non-hematological malignant bone tumor, osteogenic sarcoma. It arises from multifactorial mesenchymal tissue. Age group is very important. Only in clinical history they will give the age 15 to 25 years. Male sex, distal end of femur, upper end of tibia, that is around knee joint. Most common site is around knee joint. Classically, it occurs in the metaphysis. The three malignant bone tumors, okay, osteogenic sarcoma, Ewing's sarcoma, giant cell tumor. The three malignant bone tumors, origin, from where they are originating: osteogenic sarcoma, metaphysis; Ewing sarcoma, diaphysis; giant cell tumor, epiphysis. Okay, worth remembering this. Okay. Okay, yes, very good. So I repeat: osteogenic sarcoma, metaphysis; Ewing sarcoma, diaphysis; giant cell tumor, epiphysis. Good. Now, pain is the first symptom, swelling appears later. Why I am insisting this point? In case of osteogenic sarcoma, pain is the first symptom, swelling appears later. It's ulta in giant cell tumor. Swelling is the first symptom, pain appears much later. Okay, so in clinical history this is very important. Pain is the first symptom. Why? Because osteogenic sarcoma, when it starts the metaphysis of the cortex, it elevates the periosteum. Periosteum is very sensitive, so pain will come. Once it lifts the periosteum, that's called sunburst appearance, pain will come. But if the swelling will come only when it invades the soft tissue, that will take time. That's why swelling comes late. Okay, that's the reason. In giant cell tumor, it's an expansile tumor, so immediately swelling will come. Pain won't be there because periosteal reaction is not there in giant cell tumor. Pain won't happen. When pain will happen? When pathological fracture happens in giant cell tumor, then only the pain will come. So pain is a late feature in case of giant cell tumor. Pain is the earliest feature in case of osteogenic sarcoma. This point is very important. And osteogenic sarcoma is very dangerous because it spreads to the lung very fast. Many times the first presentation can be, yes, osteomyelitis is also from metaphysis. Afridi, yes, Afridi, osteomyelitis is also from, acute osteomyelitis is also from metaphysis. Yes, early and the early and radical ablation is the surgery of choice. So treatment of choice for osteogenic sarcoma is surgery. This is the treatment of choice. Combined approach is the best treatment nowadays. The book is telling what is combined approach. It is pre-op radiotherapy followed by surgery, that is amputation, surgery amputation, followed by post-op chemotherapy. Post-op chemotherapy. So it is pre-op radiotherapy, then amputation, post-op chemotherapy. This is called combined approach. See, dear friends, focus your full attention now because this is a tricky area. If they ask a question, best treatment for osteogenic sarcoma, single options, chemotherapy, radiotherapy, surgery, something like that, you should go for surgery. Best option is surgery. If in the choice, if they use the thing combined treatment, if they use a word, then that is better option than surgery alone. Okay, so to prevent recurrence, and BCG vaccination improves the immune status. It increases the immune status in case of osteogenic sarcoma. Immune status in case of osteogenic sarcoma. BCG. Because BCG, yes, Codman's triangle, good. So BCG increases immune status in two cancers. One osteogenic sarcoma, another is bladder cancer. Now, coming to the next question, giant cell tumor arises from. I gave you the answer. Giant cell tumor arises from, you know the answer. Just now we discussed, yes? Very good. Very good. Mukesh, you have answered it correctly. Siddharth, Afridi, marvelous. Giant cell tumor arises from epiphysis. See, giant cell tumor is otherwise called osteoclastoma. Age group is 15 to 35. Most common sex is male. Most common site is lower end of femur, upper end of tibia. Again, knee joint. This is benign, locally it acts malignantly. It arises from epiphysis. Swelling is, you see here, is the main complaint. On palpation, it gives eggshell crackling sensation. Extended curettage is the best treatment. So this again is surgery. Now, if there is one recent thing, if they ask what is the drug of choice for giant cell tumor, if they ask a question, what is the drug of choice for giant cell tumor, it is denosumab. Okay, denosumab. Very, very important question, highly expected question, man. Denosumab. What is denosumab? You know, giant cell tumor is otherwise called osteoclastoma. Giant cell tumor is otherwise called osteoclastoma. Increased osteoclastic activity. That is the problem in giant cell tumor. Increased osteoclastic activity. Right? Denosumab is a drug which increases the maturation time of osteoclast. When you give denosumab injection, it increases the maturation time of osteoclast. So osteoclastic activity comes down. Okay. Osteoclastic activity comes down. Osteoclastic activity comes down. Denosumab when you give. So what happens? Giant cell tumor will improve. So please focus your full attention. If they ask a question, treatment of choice of osteoclastoma, it is only surgery. If they ask a question, drug of choice for osteoclastoma, answer is denosumab. Answer is denosumab. Yes. Now, yes, 6-year-old child diagnosed to have Ewing sarcoma. Best treatment. Best treatment. Yes. 6-year-old child diagnosed to have Ewing sarcoma. Best treatment is? Please answer. Very good. Very good. Okay, Afridi, Neha Singh, Pujta. Yes. Excellent. This is a tricky question because radiotherapy is there. We tend to tick radiotherapy whenever the word Ewing sarcoma. But the treatment of choice for Ewing sarcoma is again surgery. Ewing sarcoma is the most radiosensitive tumor. That doesn't mean radiotherapy is the treatment of choice. It will melt with radiotherapy. Again that will come. So the definitive treatment of choice for Ewing sarcoma is only amputation, surgery. You see here, this other is called small blue cell tumor. It arises from endothelial cell of bone marrow. From bone marrow, two tumors arises, man. One is Ewing's. Another is multiple myeloma. Okay. So Ewing sarcoma arises from endothelial cells. Multiple myeloma arises from plasma cell. Okay. So from bone marrow, two malignant tumors are arising. One is Ewing sarcoma, which arises from endothelial cell of bone marrow. Another arises from plasma cell of bone marrow, that is called multiple myeloma. Most common site, again, knee joint. It arises from diaphysis. Highly radiosensitive tumor. It will melt with radiotherapy. Again, recurrence will come. So treatment of choice is only surgery. See, yes, there is cytogenic abnormality. Asked question. There is translocation of chromosome 11 and 22. Okay, the same chromosome of neuroblastoma. Okay, same neuroblastoma. Right? And so this gives what's called a pseudo rosette. This gives a pseudo rosette. Yes. And clinically, The clinical presentation of Ewing sarcoma closely resembles osteomyelitis. This was an asked question. Bone tumor which resembles osteomyelitis. Bone tumor which resembles osteomyelitis. It is Ewing sarcoma. Now, the treatment, the chemotherapy agents, this is not wide regime. If you want surgery after chemotherapy remaining tumor, not routinely. Why radiotherapy is not, it is the most radiosensitive tumor, but radiotherapy is not usually given. Why? Because you see the age group 5 years to 25. It's happening in children. When you give radiotherapy, what happens? This may go and damage the growth disturbance. It may cause the growth plate may get injured in radiotherapy. That may cause growth disturbance. So growing child, it is not advisable. Radiotherapy is not advisable. That's why surgery. Right? Identify the tumor. See, the 3 important malignant tumors we have covered, but I have not discussed the radiological features there. So this identify the tumor. What is this? What is this appearance? Very good. What is this appearance? Marvelous. Many of you had answered it correctly already. Marvelous. Superb. Superb. So this is osteogenic sarcoma. This is called sunburst appearance. This is called sunburst appearance. Osteogenic sarcoma, sunburst appearance. Now you see the appearances, the radiological appearances of malignant bone tumors. Okay. Here you see there is elevation of periosteum. Elevation of periosteum. This is called Codman's triangle. Codman's triangle. Okay. It is osteogenic sarcoma. Osteogenic sarcoma. This is sunburst appearance. Sunburst appearance. This is again osteogenic sarcoma. When you see here, this is called soap bubble appearance. Soap bubble appearance. Giant cell tumor. Okay. This is multiple layer of stripped periosteum. This is called onion peel. Onion peel appearance. That is Ewing sarcoma. This is a rare thing so far unasked. This is called moth-eaten appearance. So far unasked in any of our Indian entrants. This again Ewing sarcoma. In Ewing sarcoma, repeatedly they are asking only this onion peel. This is a reserve question. Okay. So the radiological appearances over. Now, all are risk factors for malignant transformation of exostosis except. Yes. Very good. Many of you have answered moth-eaten also. Yes, very good. Yes. Okay. Sanvi have asked one doubt. Sir, how to differentiate X-ray of Ewing's and osteogenic sarcoma? Sanvi, please focus. Sanvi, yes, focus. S-A-N-V-I, Sanvi. Okay, Sanvi. I am very glad to hear this name, man, Sanvi. My daughter's name is Sanvi. Okay? Yes. Okay. So I will have, just please focus your attention. Dear friends, others, also again, one of our students have asked a doubt, please. How to differentiate Ewing sarcoma from osteogenic sarcoma? You see. See, this is osteogenic sarcoma. This is osteogenic sarcoma. This, the third thing is, this is Ewing sarcoma. This is Ewing's. You see, periosteal reactions are happening in osteogenic sarcoma and periosteal reactions are happening in Ewing sarcoma. Periosteal reaction is not happening in giant cell tumor. Okay. The periosteal reaction can be in 3 forms. First form, just simple elevation of the periosteum. First form of periosteal reaction is elevation of the periosteum. So, This is called, you see, when you zoom your thing, the periosteum is lifted like this. The elevation of periosteum is called Codman's triangle, that is reserved for osteogenic sarcoma. Second form of periosteal reaction is multiple layers of periosteum, it moves like this, and you can't see, this is osteogenic sarcoma. Sarcoma means vascular. Sarcoma means vascular. So lot of blood vessels, lesions of blood vessels goes from the periosteum towards the skeletal muscle. Okay, blood vessels you can't see in the X-ray. Microcalcification happens along the vessel wall, and the microcalcification is seen like a sunburst. That calcification you can see like a sunburst. This is second form of periosteal reaction. Again, this happens only in osteogenic sarcoma. In case of Ewing sarcoma, again periosteal reaction is happening. How that is happening? The periosteum becomes multi-layered, multiple stripped layer, as if you are opening an onion. When you peel an onion, you can see multiple layers. Like that, the periosteum is seen in multiple striped layers, and this is called onion peel. So periosteal reaction of Ewing sarcoma is in the form of onion peel. Periosteal reaction in osteogenic sarcoma, either Codman's or sunburst. There is no periosteal reaction in giant cell tumor, so this is called soap bubble. Inside there is a lytic lesion in between trabeculated, that it gives like a soap bubble. Okay, so I think, Sanvi, I am clear. Sanvi, just give me a thumbs up sign if you are okay with my explanation, please. Hello? Yes? Okay. Yes. Okay. Right. We will move on to the next question. This is very important, and all of you, many of you have already answered this question. Cartilage, all are risk factors for malignant transformation of exostosis except, yes, except C. Cartilaginous cap thickness more than 1 centimeter is wrong. It should be more than 2 centimeters. More than 2 centimeters. Now you see this again in the topic exostosis. Again in the topic exostosis. Yes. Yes. Again in the topic exostosis. This is the very, very important question. Risk factors and signs of malignant transformation of exostosis. We all know exostosis is otherwise called osteochondroma. Most common primary benign bone tumor. Usually it is a painless tumor around a knee joint, more common in males, more common in pubertal age group, growth period, pubertal age group. It arises from the metaphysis. It arises from the metaphysis, goes away from epiphysis, go in direction opposite to epiphysis from the metaphysis. It's a painless bony mass. Only thing is cosmetic disfigurement, otherwise it won't cause any problem. But it's a precancerous condition. What are the risk factors for precancerous condition? What are the risk factors that a osteochondroma can get converted to chondrosarcoma? See, if it is solitary, chance of malignant transformation is only 1%. If it is multiple, that is multiple hereditary exostosis, chance is 5%. So this is the first risk factor, multiple hereditary exostosis. Single lesion, less chance. Multiple lesion, more chance. Number 2, there are 2 types of exostosis. One is with a pedicle, that is called pedunculated. Another is directly attached to bone, that is called sessile. Sessile is the next important. Sessile more chance of malignant transformation than pedunculated. So sessile is the second important predisposing factor. Third, sudden increase in size. Suddenly, usually after puberty, the size stops. Okay. For example, after puberty also, suddenly unexplained the size, very quickly it enlarges in size. That is a risk factor. Number 4, new onset pain without trauma. Suddenly it is becoming painful. Definitely there is no history of trauma. That is a risk factor. The definitive risk factor, you should do an MRI, measure the cartilaginous cap thickness. Okay, in MRI, definitely this is a very important. That is why, again, like shoulder dislocation, don't think MRI is a luxurious or unwanted investigation for osteochondroma. If the patient can afford, please do measure the cartilaginous cap thickness. When it is less than 1 or less than 2, no problem. If it is nearing 2, better you remove it. Because malignant transformation may happen. Finally, it is always confirmed by biopsy. Right. Now, to some extent, we have completed certain important topics, and we had done around 2.5 hours of this revision, last resort revision. And many of you, dear friends, really you are working hard, and I can see from your involvement and answering the questions, definitely you had already read ortho thoroughly. So this is our revision, we have done it. Next week we are having an exam. All the best, dear friends. Okay, all of you will get through, don't worry. Okay, so just to do this, this is okay, this is enough actually. If you want to see some extra thing, last December in public YouTube, in open YouTube, still my videos are there. Certain topics untouched here or there for FMGE. You combine this YouTube session with the 5 months back I did one thing. You combine with that, more than enough for your preparation. Okay, right? All the best. Okay, thank you so much. And see, I am yes, thank you so much. Yes, thank you. How many questions can you expect in ortho from sir? You had asked a question. Yes, yes. Okay, see, roughly 6 to 7 questions every year it is coming. Last time it was 8 questions. Okay, so minimum 7 to 8 questions is expected. So, yes, and sir, I have a doubt about pot spine location L1 and D12. See, that's why Aditya, very clearly it is given in your undergraduate book, it is written D12L1 junction. That is not right. To be more precise, it's more common on D12 because D12 is more prone for damage of the vertebra. It's the most weight bearing vertebra. This is the explanation given in Apley, and Apley is the most standard textbook. You can rely on that. D12. It is not L1. Spondylolisthesis is L1. Pot spine is only D2. Dr. Sishan, okay, MD, sir, my radial nerve compression issue, you told me that I discussed that thing. Yes. So, Dr. Sishan, just I will give my I think you are having my Instagram thing. You can contact me. Otherwise, you please mail me. My email ID is this. Okay, gmail.com. Okay, right? So you contact me. In that I will help you out. Okay, I will help you out. Sir, issue you told me I will discuss. Okay, yes. So sir, is it this in? Yes, for a last minute glance, definitely Jayashri, it is more than Jayashri, it is more than enough. And I told you, no, Jayashri, 5 months back again in public YouTube, one more video of 1 hour 50 minutes is there with me. Certain untouched topic today, I have covered that FMGE previous year question. In that, you mix that 1 hour 50 minutes video with this, more than enough, Jayashri. Yes. Okay. So, Dr. Arun Prasad Madheshwaran, at the end of the session, please share your hospital details. See, hospital details, no, I am working in Coimbatore. It's government hospital and I have private consultation also, no problem. You just see certain things. No, I had given my mail ID. You just contact through mail ID Arun Prasad. Okay, I will help you out. Thank you so much, guys. Thank you so much, guys. And right, so this is you, all the best for you. Don't worry, surely all of you will get through. Okay, thank you.